We're going to talk about what's the prostate, because most people basically don't know what the prostate is. They know it's trouble. They know it's problematic, and it's probably problematic for them. So we'll talk about that a little so you understand things. This is a very simple thing. I always say to patients, look, this is just plumbing. This isn't cancer. This isn't anything like that. It's just plumbing. I'm the plumber. We can always help you. So we're talking about a plumbing problem today called BPH, and so we'll go over that. And then we're going to talk about how urologists like me or me personally can help you. Now, different people will do different things, by the way. So this is the world according to me, but I think I do it okay. So let's see how it goes. So what's the prostate? Here, I was going through these slides a few minutes ago, and I've given talks like this for a long part of my career. And I see here the gray-haired, wise physician. And I don't have gray hair yet, but I'm growing into that. So here's a picture. And here is a side view of a man. And here is a prostate. Okay. So let's demystify the whole thing. And I'm going to try to make this as simple as possible. So if someone's having a hard time urinating, it just becomes as obvious as possible. We're not showing the kidneys, but urine comes from the kidneys and they drain into the bladder. So that holds your urine. So anything with your kidneys has nothing to do with the act of urination. And you have to get the urine from here out of your penis, and it has to go through this thing called the prostate, and it wraps around the urine channel. So if you could think of it like a bagel or a donut, you can imagine you're urinating through the middle of it. They always say it's walnut size. That's a really young guy. It gets bigger than that as you get older. And what does the prostate do? Well, it's a gland. Anything that's called a gland, it could be an adrenal gland or, carotid gland, any kind of gland in your body makes some kind of fluid. That's what gland means. So the prostate gland makes prostatic fluid, and we're not even sure what that does really. We know it makes semen more liquidy so sperm can swim away. We know it makes a substance called PSA, which we use to screen people for prostate cancer, but has a purpose, which is liquefying semen. But the prostate does not make semen. That's what you need to understand. This prostate does not make semen. And this picture, these structures hanging off the prostate make semen. Those are called seminal vesicles, and they drain through the prostate. So if someone asks me, what is the prostate? From a plumbing term, I say, well, it's kind of amazing that a male human body uses the same pipe for two different systems, their reproductive system for semen and their urinary system. And the prostate is kind of that junction valve that kind of switches between the two. So there's a purpose. It's more of a mechanical purpose, okay? And the key to understand is it's tiny when you're small, but it starts growing in your mid-40s and it just keeps growing. And sometimes that growth causes trouble with urination. And again, we call it prostate, not prostrate. Prostrate means you're frustrated about something, basically. But prostate, when someone says, I have prostate, some people will say, I have prostate. And I don't know what that means, because they're telling me they have trouble with their prostate, but that could be one of these three categories. So let's go over the things we're not going to talk about first, and then let's focus on enlarging prostate, which is just a part of getting older. Number one thing, and we'll talk about this later, the first thing that happens when I see patients are going to be in one of three categories. The first patient is going to be the patient. I was that person probably when I was 48, 49, I'm 55 now, where you first start to notice a difference with your urination. So you're starting to now say, what's going on with me? Why do I have to get up at night once? Why is my stream not as strong? Why do I urinate more urgently? And every man, it goes through their mind, could this be the sign of prostate cancer? So the first patient, who's usually about 50, is seeing me largely to make sure that they're okay. And I can tell you that 99.something% of the time, urinary symptoms are not from prostate cancer. So those patients are reassured. There is a test called a PSA. There's a webinar, etc., on my website talking about what is PSA and how do I use it. But enlarged prostate is not prostate cancer. It's a completely separate thing. And the two are usually mutually exclusive. And then this term prostatitis, it's a little bit of it's a catch-all phrase for just somebody that has some irritative symptoms down there, etc. These days, it's very sexy to call that pelvic floor problems, pelvic floor dysfunction. Unfortunately, most men that have some irritation, they always think they have an infection, and they go to an ER, an urgent care, or an internist. They're always treated for infection, but it's almost never an infection. So prostatitis just means unexplained symptoms, and they tend to be a little different than just your standard plumbing issues of enlarged prostate. So we won't talk about that too much, but there is some overlap. We're going to talk about enlarged prostate. And this is, it's always great when they show these schematics. I'm trying to figure out how old this person is. He's probably in his mid 40s, but that's kind of when it first starts. You first start to notice a difference then. And the key to this talk is to understand this is just a slow, progressive process. It tends to get worse, and people get used to it getting worse. And that's one of the reasons I give these talks. And I tell patients in my office all the time. I had a patient today. This is the end of a very busy day, and he gets up 5 times a night, but he's used to that. And he's scared of what the treatments would be if he addressed it. So he just gets used to it. And I always say to patients, and this is why I give webinars, this is why I have a website that I try to get people to go to. I felt that that patient might have fear of the unknown. And what we're here about today is to let you have fear of the known, and then let you decide if you want to help yourself with this problem. And so what is BPH? Again, it's just, I try to just make it very simple. Our prostates grow as we get older, okay? Hyperplasia means it gets big. Benign means it's not cancer. So this is the take-home message, and it's just part of getting older as a man. It's very rare to see a man that urinates the same when they're older than when they're younger. So I try to just say it's just part of getting older. There's a lot of getting older. This is just one of those things in a man. Okay. This slide talks about, again, what I've already talked about. No, that doesn't mean you have prostate cancer. And again, I spend a lot of time just reassuring people it's not a problem. The PSA test, and again, that's a complex discussion, and let's kind of leave that to other avenues, especially my website. But the PSA, it does have overlap. If you have a big prostate, you tend to have a higher PSA. And I spend all day telling people, no, let's not worry about that. That's from your enlarged prostate. The key take home about PSA, if I was just to tell you about it very quickly, is the PSA should be used as a trend test. I don't really get upset ever about a PSA that's elevated. I get upset about trends. And I mean, if a PSA is extremely high, that's a different story. And the trend of enlarged prostate, or aging, I like to call it aging, is a PSA that slowly drifts up and levels out right about the borderline. And I see patients all day that I'm just showing this trend and showing we're okay. And prostate cancer tends to keep going up. So that's a very quick discussion of that, but that's not what we're here to talk about. This slide is a little bit silly, okay? But it's just showing, if you have a big prostate, you can imagine it's hard to urinate through this thing. And it explains all the things that go with it. I have to go suddenly. I have to go at night. I don't empty my bladder. It's like I have to go more than I normally have to go. I have to think about it like I didn't have to before. And I'm in that club now. But one thing to point out here is you can have a huge prostate. Think of a bagel. You can have an enormous bagel, but if the hole doesn't happen to get smaller, it doesn't matter if you have a huge bagel. You're going to urinate just fine. So when someone says to me, I have an enlarged prostate, I'll say, what does that mean to you? Well, my internist told me it was enlarged. That doesn't mean anything to me. If a person has symptoms and he's saying, I'm seeking help for that, that's what we urologists call the phenomenon of BPH. Everyone has a prostate that grows. Some people have a lot of symptoms from it. And, maybe if you're on this webinar, you already have some of these symptoms. Have to go frequently. Well, women have that too. You could just have overactive bladder, but this thing here, weak flow, we men have that. I can tell you, no one asks for treatment for that. Most patients don't know if they're emptying their bladder or not. What patients ask for help for is because they go frequently, or they go urgently, where they're worried that they might urinate on themselves, or they get up at night. But these are the symptoms that we're talking about. None of these really usually are from prostate cancer. I'm going to kind of skip over this slide because it's basically saying it's extremely common and it's a part of aging and it's just part of life. Who gets BPH? Everybody. Who's affected by it, where they say, I want treatment, a lesser percentage. That's the bottom here. So I'm just trying to say it's just a part of getting older here. And how is it diagnosed? How do I know that you're having a problem with this? The mainstay, if any of you have seen me in the office, and a lot of you, most of you probably have, is before I come in the room, I would have already had you fill out this survey right here, which is revolutionary. It's going to tell me in 2 seconds, does this look like just a guy who's obstructed? And do the symptoms, are they consistent with that? Or is it someone that just has overactive bladder where we'll go in a different direction? And I would have already looked to see, are you emptying your bladder adequately or not? Because those are that's something I need to do, because that's one of the few circumstances where I may tell you, you need to do something about this. You shouldn't not do something about this if you're very much not emptying your bladder, because as it stretches out, eventually it'll get so weak that it won't be able to do its job anymore. So most of the time I'm not, and it annoys some patients, I'm not telling them they have to do something about this. I'm teaching them about it, and I'm saying to them, you do something about this when you're bothered enough. But there are circumstances where I tell patients to do something, where they're ruining their bladder, where they're getting all these infections, where they have all these other problems, or in the worst case scenario, hurting their kidneys. The digital rectal exam isn't really how I diagnose this, because again, how big or small your prostate is doesn't matter. It's how big the bagel hole or the donut hole is. So plenty of patients, I did a lot of procedures last week or this week, and most of those patients had relatively small prostates, but that doesn't mean you're not obstructed by it. It's just a function of, does your prostate grow only outward, or outward and inward, or only inward? It's the inward growth that's going to cause your trouble, just like a pipe that's clogged. So that's enlarged prostate. So how can we help you? Now, this is where what I do varies in a large part from what's on this slide. So let's use this slide, but let's make it a little bit different. We've already talked about the first patient that sees me is that person in their late 40s, early 50s, that they're noticing a change and they just want to make sure they're okay. Okay, which really means they want to make sure they don't have prostate cancer. And that's this person. What are they going to do? I'm going to ask them, are you bothered? Now that you know everything's okay, are you bothered to the degree that you want to be treated? That's a different question than, are you getting up at night? And most of these patients at the early stages say, no. And I say, okay, then let me know when you reach that point. Those people might say, I'm just going to not drink a lot of water at night. Because I know if I drink a lot of water at night, I'll be paying for it. I'll be up at night. But watchful waiting just means let's just see what happens. Kegel exercises, this really has nothing to do with this. So let's just not talk about that. Now, this is where this slide very much differs in my practice. If the patient says, no, I am bothered enough now, I want to be treated, my first line therapy, period, is medications. And I feel that way because of the following analogy. So I'm going to dive into an analogy right now. And it's an analogy I try to use with patients because I think it's the most demonstrative, and I think it's a perfect analogy. Anyone who owns a house, anyone who owns a condo, stays in a place long enough, especially if they're married to a woman with long hair, like me, will have experienced a bathroom sink. Not a kitchen sink. If the kitchen sink is clogged, you're in trouble. You have to fix that. But a bathroom sink starts to go slow. And it's not sudden. It's a slow progression, just like BPH. And every person, like myself, has a threshold where they might say, all right, I'm annoyed enough now to do something. My threshold is when my shavings in the sink don't go down right away and I have to come back and wash them down, or my wife will yell at me. That's my threshold. And What's anyone going to do at that point? They're not going to snake their sink necessarily. They're not going to call a plumber typically. They're just going to grab some Drano from the grocery store. That's pretty much what everyone would do as a first line. Drano is medication. We're going to talk about that. Now, if Drano works well, you're not going to do anything but say, I'll just put some more Drano in there in a month or two. That's what I would do. And that's what I found that patients do. So I want them to experience at least what would Drano do before we talk about more aggressive things. But if the Drano doesn't work well, and that happens all the time, or you're putting it in constantly, that's where when a patient comes back and says that didn't work, that's where that patient should be told, just as the homeowner would be told, well, now you ramp it up to the next step if you're interested in fixing your sink. The homeowner would just get a snake from Home Depot or do some remedy like that, or get stronger Drano from the hardware store. And in my practice, what that next step is are office procedures. That's what I call them. And that's what these two would be. Okay. The one I do most commonly is called Resume, and that's what they're calling water vapor therapy. Its predecessor is called Tuna. Did that for many, many years. And in some circumstances, I still do that. And then the other competing procedure, which is extremely heavily marketed, and I don't favor, and I'll explain that, is called Eurolift. And that's got TV commercials, and the big, huge super groups around town, they tend to promote that. It tends to be quite lucrative. And then most patients, if they understand that as an option, theirs are so easy to do, you would try that next. You try the snake next. But if the snake doesn't work and everything doesn't work, or you're putting your house in jeopardy, you're going to go straight to the thing that's going to work, which is call the plumber or do it yourself. Take the pipes off, snake the pipes. I do that myself. It's a terrible job, but that sink is going to work when I'm done with that. And those in my practice are called operating room procedures. So these are all operating room procedures. Shaving out your prostate, we call that a roto-rooter. That's called a TURP. I'm not a big fan of green light laser, but a lot of people have heard of that, and urologists will offer that in their surgery centers. And prostatectomy, in my hands, actually isn't a knife. It's a robotic instruments. But if you have a very big prostate, sometimes I'll tell you, you're not a good candidate for these. You need to go straight to this, and we're going to open you up. So the concept here is that of progression. BPH progresses, and what we do about progresses. And I have found, very much so, that when patients understand that once that medicine doesn't work and they're coming back to say it didn't work, if they're educated on the next step, they almost always choose one of these procedures because they're easy and simple. And they tend to have misconceptions that these procedures are equal to the operating room procedures, or worse, that they're equal to cancer surgery operating room procedures, which have a whole other bevy of side effects, etc. So I always say, go to my website, figure out if you want to be helped. Let me know when you want to be. And if you're unwilling to be, I'm willing to give you more medicines. I'm willing to double the dose of medicines, which in my analogy would be, I'm going to pour the whole bottle of Drano in and see if that works. And we know that that's not really going to work. Or I'm going to put 2 brands of Drano in and see if it works. I think if you saw yourself doing that to your sink, you'd say, or your partner or your wife would say, what are you doing? Why don't you get the sink fixed? Why are you doing all this? It's clearly not working. And I can't help but think that when I see that people are on 2 medicines and an herbal medicine, it's a function of outreach to let them see on their own, without being talked into anything, there are very easy ways to fix this that are not scary. So that's why we're here tonight. And that's why my website exists. This slide is kind of strong. It seems to say, don't use herbal remedies. Talk to someone today who wanted to do that. If people are doing that, again, it's the same as saying, I'm not willing to do anything else. And as long as they know about the procedures and they're making that choice, I don't push them in any direction if they're not hurting themselves. But saw palmetto sometimes works. Most randomized studies have shown it doesn't work like most herbal remedies do. But if a patient's not willing to do anything else, I usually say, well, if you're not willing to do anything else, you may as well try this, or you may as well double the dose of medicine. But I have actually found, and my partner moved to West Virginia, and he didn't commonly offer patients procedures, And so most of them are all on several medicines or double dose. I have very few patients on double dose because I offer procedures. They read about it, and then they come back and say that's the logical choice, kind of like the snake for the sink. But that's up to you. We can skip through this. Watchful waiting just means I'm not going to do anything right now because you've told me I'm okay, and I don't want to do anything right now. And we just take a wait and see approach. The mainstay of medications, if I put you on them, are called alpha blockers. Examples in their generic forms would be tamsulosin, that's Flomax, alfuzosin, that's uroxetrol, silicodin, that's Rapaflo. Okay, Rapaflo has a serious, almost everyone on Rapaflo doesn't ejaculate very much, so I don't use that much. Flomax is the most common, but it has more side effects than alfuzosin. So they're all interchangeable, but alpha blockers are the mainstay. That's the main type of medicine that we use. That's what I always try first. And it's important to say, I'm going to make you try that. It doesn't mean you have to say, I'm going to stay on it for the rest of my life. If someone says it worked, but if you're telling me I could do some 5-minute procedure and that would solve my problem, I'd rather do that than be on medicine the rest of my life. That's a very valid statement, but I at least want someone to experience the medicine so they can make that statement. Objectively, one of the reasons I don't like that Eurolift procedure is the whole marketing plan of that, and the approach by many big groups that do it are they offer it instead of medicine. And philosophically, that's not my own philosophy. And I know that many patients wouldn't choose a procedure if a single pill each day solved their problem. I know that, so I know that they should be exposed to medicine first. Now, the other types of medicines are called 5-alpha reductase inhibitors. Examples would be finasteride or dutasteride, Proscar or Avogard. Now, the finasteride was the original miracle drug. Before that, everybody got an operating room procedure, but then it was pretty much shown it doesn't work any better than sugar pill. Sugar pill actually works very well for these types of things, and it kind of fell off the market. It was marketed for hair loss. It is something I will use if you have a huge prostate, because this is what shrinks your prostate. Marketing wise, everyone thinks, well, that sounds great. If it's going to shrink my prostate and my problem is from enlargement, then this is the medicine to take. The problem is, if you could think about a bagel, it shrinks your bagel, but it doesn't open the hole. The bagel hole stays the same. So it doesn't tend to help you at all unless you have a huge prostate. It also takes about 6 months to have effect. So by the time I have a patient that's very annoyed, this doesn't have much role in my practice. And there's weird things that can happen with this. There's sexual side effects. There's rarely reported long-term effects from these drugs. So I will do this if a patient says I'm not willing to do anything else, but patients will commonly in my practice say, I'd rather try some 5-minute procedure than be on 2 or 3 medications, et cetera. So that's those medications, but they are there. And now this slide deck starts talking about treatments, okay? So now we've talked about doing nothing but being reassured. We've talked about medicines, and now we're going to talk about office procedures. So water vapor therapy is a description of a procedure that I do called Resume. Resume is made by Boston Scientific, so that's why they're helping us tonight. Resume is a more advanced version in some ways of its predecessor, which was called a tuna. In both of these procedures, the idea is we're going to look into your prostate. We're not going to cut anything. We're going to put some needles under the surface, and then we're going to heat the tissue. So it's not frying it. It's sort of heating it gently, kind of like the microwave thawing out a frozen turkey. And then that tissue will kind of die and wither. Your body will reabsorb it, and the hope is that things open up so that now your bladder is happy enough to empty, et cetera. So there are certain patients that I do tunas on, but Resume tends to be my mainstay now. They both work well. The reason I'm a big fan of Resume, because I had been a big fan of tuna. The advantage of Resume over the tuna is that it's much faster. I used to say, I'd given a previous webinar where I got the impression that it hurt more because it is more intense. It's much faster, each treatment is only 9 seconds versus 2 minutes and 20 seconds for the tuna, kind of like an iron when you press on the water button. But now I've kind of developed a way now to numb the prostate, which seems to be incredibly effective, such that it absolutely is not more painful at all. So that kind of pushed me over the edge. It's a bit more intense, where some patients have a little harder time urinating after the 2 days they have a catheter. But I do get the sense that it has a higher success rate in the tuna in properly selected patients. So I'm kind of shifting over to this, a bit more of my mainstay with tuna for certain people, okay? And that's what it is. So the difference between the two, tuna is needles that just vibrate and make heat. This is a single needle that has water droplets coming out the end. So the heat turns into, the water turns into steam, which lets it spread out, require fewer treatments, and it goes much faster. So this is what I'm a big fan of. It's not marketed like the Eurolift, but it is, I've had extremely good success. I've done a lot of these. I would say I'm seeing about an 85% success rate in my patients, whereas tuna was more probably about 80%. So this is the way to go if you're the right patient for it. And then the competitor is called a Eurolift, or they call it a prostatic urethral lift. What is this? Well, this is basically firing sutures through the side of your prostate, outside the prostate, and kind of like a grappling hook. I usually say kind of like the bat hook. You guys are probably old enough to know what the bat hook is, and then it catches the gutter and then you pull this way up there. That's what it does, and then it mechanically pulls your prostate open. The marketing pitch of it is that it works faster than the Resume because it doesn't have to kill anything. The marketing pitch of it is it has less chance of affecting how much semen you ejaculate. I always say the tuna and the Resume is going to have about a 20% chance of affecting that to some degree. Again, since I don't talk people into these things, by the time you're asking me for one, most men already have trouble in that department because they're on medicines or their prostate doesn't allow the drainage of the semen. So I haven't really found the semen thing at all to affect my practice. Why I'm not a fan of this is because I believe that an office procedure should be very low risk and highly successful, where you have very little to lose. You can get bleeding in your pelvis if you hit a vein when you shoot these things, and you also are leaving foreign bodies in your prostate, which is just something that's very, very not what I'd want to do. They get infected, they get misplaced. If they're not, I've seen a lot of people with trouble from Eurolifts, and I think the word's starting to get out that it's not all it's cracked up to be. It's very popular, it's very marketed, and it's pushed instead of medicines. But as you can see, that's not really my philosophy. So it's not that it's a terrible procedure. It just doesn't jive with my philosophy. And I think the Resume or the tuna is much better. It's not as lucrative, but it's much better. So those are the mainstay of office procedures. In the past, there's been other ones: microwave, hot balloons, all these things that come and go. But the ones that have stuck, in them two main competitors are Resume and Eurolift, and I still sometimes do a tuna. And now we're going to talk about operating room procedures. And the one that I think is the most controversial, and Boston Scientific makes this, but I'm not an enormous fan of it, is called a green light laser. And there's other lasers. And that's because green light laser is marketed to patients as a minimally invasive, easy thing, that it's a lot less than the competitor, procedure, which is called a roto-rooter job or a TURP, and we'll talk about that. But it has to be done in an operating room, and you're asleep on the table, and it doesn't have any fewer side effects than the better shave-out procedure. So my own philosophy is, if you're already on the table and you've already gone through the trouble of having anesthesia and everything that goes with that, I generally do a TURP, a shave-out procedure, because it works much better, way fewer complications, much longer duration of success. And so I'm not an enormous fan of the green light laser. It tends to cause a fair amount of scarring too, but it's a popular thing because it can be offered in a surgery center. And while we're on that topic of how long the procedures last, I forgot to say that those office procedures, Resume, tuna, etc. That's going to last about 5 years when it works. So we do it. You have a catheter for a few days. You come back and see my nurse practitioner. We make sure that it's an easy landing for you. And then you stay on your medicine, you wean your medicine off, and then people come back. And when it works, it's like a home run. It's you no longer have a problem. You're going to fill out your urinary survey, and it was very bad before, and now it's great. And that's about 85% of the time. And if that happens, it's going to be durable for about 5 years. It doesn't mean you're going to be as bad as you were in 5 years. It just means it shouldn't be a shocker that your donut hole starting to, just like the sink, you cleaned it up. Eventually, it's going to get clogged again. We usually go through the same discussion 5 years later. Now I can tell you that most patients are so happy at just going right to this 5-minute procedure that they don't usually ask me for medicine. They want me to do it again. And these procedures, the office ones, can be done again. So I forgot to throw that in. So green light laser, not a huge fan. I use it in very specific circumstances as an OR, operating room procedure. The mainstay of an operating room procedure should be, in my opinion, a TURP, a transurethral, that means through your penis, so it's through a scope, resection. Here it means we're actually cutting something. We're shaving the tissue out, like a roto-rooter job. That's like you've rooted out your pipes, you've done the auger, you've done the thing for your pipes, and now you're wide open. Now you could say, how come everyone doesn't do that? That's going to have like a 95% success rate. Why would you choose something with a lesser success rate? Well, here you have to now talk to the patient about things like, well, there's a very small, but there is a chance of incontinence with this. There is a chance of bleeding, complications. You have to often stay overnight. I'm trying to start doing these as an outpatient, but this is kind of stepping it up. And when people hear, well, why would I jump to that? Why wouldn't I? And by the way, the green light laser has the same risk. So most people, when they're presented all their options, the logical option tends to be an office procedure. But with me, there are circumstances where I'm not going to offer that. There's patients that just don't know that they're not emptying, and they finally show up and they've got so much retained urine, they're hurting their kidneys, or there's a medical problem, and I have to intervene. And that's where we're going to go to the operating room. And in my practice, it's either going to be this roto-rooter job, or it's going to be, in my practice, if you have a very big prostate, especially if you have stones in your bladder also, it's going to be something called a robotic simple prostatectomy for me. There's other procedures that I can recommend that other people do for really big prostates. There is a laser procedure that's an excellent procedure for that called a HOLEP. And usually, there's a couple people in town that offer a robotic simple prostatectomy because it's actually harder to do that than it is a cancer operation. And there'll be 1 or 2 people around that offer a HOLEP. And there's something else called aquablation, but that's kind of beyond what we're here to talk about. But I kind of do a lot of robotic surgery. So for me, my skill set is I go to robotic simple prostatectomy when you have a huge prostate. Huge being, if anyone knows the prostate size, over 100 grams. I mean, huge is 400 grams, but at some point it becomes a lot simpler to shell out the inside and not do a shave out procedure. So those are operating room procedures. But in my practice, the vast majority get an office procedure because that solves their problem, and they're happy, and they don't move on to the next. Insurance coverage wise, I'm not sure. I've never seen insurance not cover procedures. I mean, it's a lot cheaper for patients to be fixed, especially they want to do an office procedure because they don't have to pay an operating room. So insurance is not an issue. And again, this is just a summary of the progression that we talked about. There would be watchful waiting. First line therapy would be, for me, medical therapy. Then second line therapy would be office procedures. And then third line therapy would be surgical procedures, just to correct that slide. And I think I'm about done. I'm going to change the slides. I hope this has been enlightening for you. Bottom line is I'm always reachable. Happy to see you in the office. We can answer further questions that we don't answer in our question session.